We will discuss in this video and in the next video some of the most common connective tissue diseases, of which SLE or systemic lupus erythematosus is the most common one. So let's start with SLE. Let's start with a vignette. Here we have a 17-year-old girl presented with pain in her knees and wrists, with morning stiffness. The patient also complained from chest pain, which was affected by respiration. She told you that she had oral ulcers several times over the previous year, and she noticed a rash on her face, especially when she was exposed to sunlight. On examination, you noticed some oral ulcers. There was tenderness and a swelling of the wrists and knees. Apart from this, the examination was normal. So, you ordered initially complete blood picture, ESR, C-reactive protein, and chest X-ray. The results came later as following. Hemoglobin was 9.5 gram per deciliter, so the patient is anemic. White PC count was 6,000, ESR 56 elevated, C-reactive protein 3, which is normal, and the chest X-ray was normal. Then you sent her for other tests, rheumatoid factor, anti-CCP, anti-double-stranded DNA, anti-nuclear antibody, and urine analysis. From the case, from the history, you suspected that this condition may be related to some rheumatological disease. So you ordered these tests accordingly. Now, let's leave the case for a while. So, how to diagnose SLE? SLE, or systemic lupus erythematosus, is diagnosed by a specific criteria which is composed of 11 points. If the patient has 4 out of these 11 points, then the diagnosis of SLE is certain. And that is why I put this slide here. I am telling you that you can diagnose SLE maybe from the history alone, from the history and the physical examination. SLE can be diagnosed. So what is this criteria for SLE diagnosis? It is abbreviated as MD, SOB, brain. Each of these 11 letters, each one signifies 1 point from the criteria. So in MD, the M stands for malar rash, the D for discoid lupus. In SOB, the S for serositis, the O for oral ulcers, the A for arthritis, the P for photosensitivity. In brain, the B for blood disorders, R for renal disorders, A for anti-nuclear antibody titer, it has a specific entity in this criteria, the I for immunological disorders, and the N for neurological disorders. And we will go in details into each one of these points in this criteria later. I'm just telling you that you can diagnose SLE from history and physical examination alone. Okay, let's return to our vignette. The results came later, showing anti-nuclear antibody titer of 320, so it is elevated. Anti-double-stranded DNA was positive. Rheumatoid factor was negative. Anti-CCP negative. And the urine analysis showed proteinuria. So we have some questions here that we will try to answer throughout our study. What is the diagnosis? And we can answer this now. We have a patient who has arthritis, oral ulcers, skin rash with photosensitivity, an elevated anti-nuclear antibody titer, positive immunological findings, renal findings, and this is certainly more than 4 out of 11. That is why this patient is diagnosed with SLE. Okay, so question number 2, what is the pathological feature of the disease? What is the most commonly affected system in this patient? And what is the most specific test? We will try to answer all these questions throughout our study. Okay, so what is SLE? SLE is an autoimmune connective tissue disease characterized by antibodies against nuclear components. So this is a feature of SLE, antibodies against the nuclear component, of which anti-nuclear antibody is one of them. Okay, this SLE disease is a multisystemic disease. As we will see, it will strike every single organ in the body. Okay. We have some epidemiological and genetic points that we need to illustrate. SLE is actually a disease of female. It is 9 times more common in females than in males. And there are many theories that suggest why SLE is more common in females. One of them is an autoimmune disease, and most autoimmune diseases are more common in females. Also, problems or defects in the X chromosome is suggested because SLE is more common in conditions where the patient may have multiple X chromosomes, like Klinefelter syndrome. It's more common in Klinefelter syndrome. Also, the condition may be related to sex hormones, especially estrogen. Okay. This disease starts early in life. Most patients present within the 2nd and the 3rd decades of life. And this is a point where it differs from rheumatoid arthritis. Rheumatoid arthritis is also more common in females, but it is a disease of middle-aged females, patients within their late 30s and 40s, while SLE usually present in the 2nd or 3rd decades of life. Okay. The genetic factors are very wide in SLE. And the most important may include congenital deficiency of complement factors. This is very important in the pathogenesis of SLE, as we will see. Also, mutations at the major histocompatibility complex is evident in SLE, including mutations at the human leukocyte antigen at the DR2, DR3, B8, and A1 locus. And there are many other genetic defects in SLE patients, but these are the most important. Also, there are some environmental factors that may lead to, or that may trigger the onset of SLE, including UV light, drugs. We will talk about drug-induced lupus later, and infections, specifically infection with Epstein-Barr virus. Infection with Epstein-Barr virus is thought to cause SLE by cross-reactivity. The antigens of EBV may be similar to human antigens, and this can trigger cross-reactivity that lead to pathogenesis of SLE. Okay, so this picture shows us the main etiological factors in SLE. We have female factors, the hormones and the X chromosome. We have genetic factors, the complement deficiency and MHC mutations. And we have environmental factors, Epstein-Barr virus infection, exposure to ultraviolet light, and some drugs. All these can trigger SLE. But the question is, why SLE doesn't occur in every one? I mean, most of us are exposed to at least one of these factors. So why SLE strikes specific number, specific people, not all, not everyone? Okay, this what we are going to answer in the pathogenesis of SLE. SLE is sometimes described as a disease of defective apoptosis. Apoptosis, when there is apoptosis, cellular fragments will be taken by dendritic cells. I'm talking about SLE patients. Cellular fragments will be taken by dendritic cells. These dendritic cells will process these fragments into antigens and then present these antigens to T lymphocytes. Then T lymphocytes will activate the B lymphocytes to produce antibodies against self-antigens, against the cellular components. These antibodies will attack blood components, the RBCs, platelets, and white PCs, in a type 2 hypersensitivity reaction, in which antibodies attack self-antigens. And then these antibodies will reactivate dendritic cells, causing dendritic cells to produce cytokines. These cytokines will cause inflammation. Also, some of these antibodies will form immune complexes with their antigens, and these immune complexes will be deposited in various organs by type 3 hypersensitivity reaction, which include the formation of immune complexes. So, if we are asked what is the pathological hallmark, actually immune complex deposition is the pathological hallmark of SLE. But again, why this doesn't happen in everyone? I mean, apoptosis is universal. It is happening continuously in our bodies, but not everybody gets SLE by apoptosis. And here comes the role of complement deficiency. Normally, when there is apoptosis, cellular fragments are rapidly removed by the complement system before they are taken by the dendritic cells. So at this step, when we have complement deficiency, dendritic cells will take the cellular antigens, the cellular components, and present them to T cells. Also, the complement system is involved in a process called negative selection, by which each self-reacting B cells, I mean the B cells that react against self-antigens, are killed early in life. In this process, negative selection, complement system plays a major role. So if we have complement deficiency, then self-reacting B cells will remain in the body, and they may attack, and they may form antibodies against cellular self-antigens. So, we can see that in the pathogenesis of SLE, there is complement deficiency play a major role. The innate immune system by the dendritic cell play a major role, and the humoral immune system by B cells play a major role. So we have complement deficiency, we have activity of innate immune system, and we have activity of humoral immune system, the adaptive immune system. Okay, so this picture shows us the pathogenesis in SLE. We can see we have a triggering factor like UV light at the top of the image or virus at the side of the image. This will trigger apoptosis. Then the apoptosis will lead to cellular antigens. These cellular antigens will be taken by dendritic cells because there is complement deficiency. You can see CD here signifies complement deficiency. These autoantigens will lead to formation of autoantibodies because we have loss of tolerance. There is no negative selection. B cells reacting against self-antigen will produce antibodies against cellular self-antigens, and this will result in formation of autoantibodies, as we said, or immune complexes. Some of these autoantibodies will reactivate dendritic cells to produce cytokines, which will result in inflammation and lead to more apoptosis, and this is a positive feedback cycle. Okay, this image also shows us the positive feedback loops and amplification loops that occur in SLE. In the center of image, we have the genetic predisposition, maybe the complement deficiency. Then we have an environmental trigger. Let's say UV light. This will result in the activation of innate immune system, specifically the dendritic cells, which will present antigens to adaptive immune systems, specifically B cells, which will produce antibodies, which will form immune complexes. And at this stage, the cycle will repeat itself because the immune complexes will activate the dendritic cells to produce cytokines, which will produce more apoptosis, and so on. Okay, so this is the pathogenesis of SLE. Okay, now let's get into the clinical features of SLE. We have discussed some of them briefly in the clinical criteria for diagnosis. Okay, we have skin lesions. Skin lesions are very common in SLE and very wide. We have malar rash. Malar rash is actually a rash over the cheeks that specifically spurs the nasolabial folds. This is a characteristic feature that gives the rash a shape of a butterfly rash, which is an area of redness over the cheeks that spurs the nasolabial folds, is characteristic of SLE. Okay, this malar rash is painful and itchy and increase with sun exposure. Okay, we have also discoid lupus. This is an area of patchy redness that can lead to permanent scarring. Also, there is photosensitivity, oral ulcers, as we said. These oral ulcers can be painful or painless. We have alopecia, which could be non-scarring, which is reversible with treatment, or scarring, which is irreversible. And there's also livido reticularis. Livido reticularis is actually a lace-like rash, which is characterized by areas of purple discoloration surrounding palar areas. This is seen in many conditions, and it's maybe seen in SLE. Okay, this is the butterfly rash. You can see how it spurs the nasolabial folds. Okay, so skin manifestations are very common in SLE, and you can see about 3 of them are present in the clinical criteria for diagnosis. This is livido reticularis. You can see areas of purple discoloration surrounding palar areas, which will give a lace-like appearance. Okay, joint manifestations. The most commonly affected system in the body in SLE is the musculoskeletal system, not the skin. If we are asked what is the most commonly affected system, it is the musculoskeletal system. In the joints, we may have arthralgia, which is associated with early morning stiffness, and it's migratory, so it is an inflammatory type of arthritis. Okay, so we have arthralgia, arthritis. Then, but deformity is rare in SLE, and erosions are very, very rare. There is no erosive erythropathy. There is a condition called Charcot erythropathy, which results in subluxation of the metacarbophalangeal joints from the 2nd to the 5th finger. This results in ulnar deviation. This condition was initially described for post-traumatic fever erythropathy, but now this condition is rare, so the most common cause of Charcot erythropathy nowadays is SLE, but it is also non-erosive. And there is also a vascular necrosis of femoral head. It has a higher prevalence in patients with SLE. Okay, this is a picture of Charcot erythropathy. We can see there is ulnar deviation of the fingers at the metacarbophalangeal joint, and apart from this, the joint X-ray is nearly normal in SLE. If the patient has no Charcot erythropathy, his X-ray would be completely normal. Okay, other systems, as we said, all systems can be involved by SLE, and if the disease is only involving the skin and the musculoskeletal system, then this is a mild form of SLE. But when the renal and the central nervous system began to be involved, then the patient is entering a more severe form of the disease. In the cardiovascular system, the most common manifestation is pericarditis. Okay, the patient may also get Lippmann-Sachs endocarditis, and this is a specific type of endocarditis in which there are non-bacterial sterile vegetations formed at the endocardium and the heart valves. Also, there may be Raynaud's. Raynaud's phenomena is common in SLE. Actually, a common representation is arthritis with Raynaud's phenomenon. Okay, in the renal we have lupus nephritis, which is very common in SLE. It is a proliferative glomerulonephritis that can present with proteinuria, hematuria, and hypertension and renal failure. This condition has many stages, 6 stages specifically, but we are not going to discuss them here. So we need to take a renal biopsy. If the patient has proteinuria, we may need to take a renal biopsy not for diagnosis, but to plan for treatment. We do not use biochemical agents without renal biopsy. Okay, in the GIT we said there is mouth ulcers, and there is a mesenteric vasculitis, which is an emergency in SLE. In the central nervous system there are many manifestations. The patient may have seizures, psychosis, i.e. hallucinations. There is peripheral neuropathy, cerebellar ataxia. Many manifestations can be seen in the central nervous system, but these are the most important. In the respiratory system there is a pleuritis, and there is pneumonitis, alveolar hemorrhage, fibrosis, but these are rare. In the hematological disorders, the most common hematological disorder is anemia of a chronic disease. Anemia of chronic disease is the most common hematological disorder in SLE. Other disorders include hemolytic anemia and pancytopenia and leukopenia, which result from the autoantibodies that attack the blood components. Okay, so these are the most common. These are not all the manifestations of SLE, but these are the most common. Here, this is a picture, histological picture of the lupus nephritis. This lesion is called the wire loop lesion. It is specific for SLE, and we can see there is thickening of the capillary loops within the glomeruli. Okay, this is a picture showing us the most important features. You can see in CNS there may be seizures, in the skin butterfly rash and lupus, discoid lupus. In the heart and lung there is pleuritis and pericarditis. In the kidney there is a glomerulonephritis. In the blood, anemia, which could be anemia of chronic disease or hemolytic anemia, leukopenia, thrombocytopenia. There may be also arthritis. Okay, now let's talk about the immunology. This is very important in SLE, the antibodies of SLE. There are so many antibodies in SLE. In one study, there may be more than 100 types of autoantibodies in SLE, but these are the most important. We have the anti-nuclear antibody. This is the most sensitive. Its sensitivity can reach to 98%, but it is highly non-specific. It may be present in 5 to 10% of healthy patients, but it is a useful initial test if we suspect SLE because it's highly sensitive. We have the anti-double-stranded DNA. This is important in disease activity. We can measure disease activity by anti-double-stranded DNA. We have the anti-Smith antibody, and this is the most specific test. But it has low sensitivity, 20 to 30%, but it is, if we are asked what is the most specific test for SLE, it is the anti-Smith antibody. Okay, we have anti-Rho and anti-La antibodies, and these are important because they are associated with congenital complete heart block. These antibodies may pass through the placenta from the blood of the pregnant patient to her fetus and present as congenital complete heart block. Okay, and we have anti-ribosomal P protein antibody. This is uncommon in SLE, but it is associated with lupus cerebritis. These are important for us students because they highly come in exams. They like to ask about about these stuff. Okay. Disease activity. How we measure disease activity? We have 3 criteria. There is elevated ESR, but the C-reactive protein is normal, and we don't know why C-reactive protein is normal in SLE, but this is highly specific. I think it's also seen in systemic sclerosis, and in SLE C-reactive protein is normal while ESR is elevated. We have also, as we said, elevated anti-double-stranded DNA titer, and there is decreased level of complement factors. So 3 criteria: elevated ESR, elevated anti-double-stranded DNA titer, and decreased level of complement factors. Okay. Now some points about drug-induced lupus. Drug-induced lupus usually take a mild form of the disease. Only the skin and the musculoskeletal system is affected, and the most commonly the most common agents include the hydralazine, antihypertensive, procainamide, antiarrhythmic, and isoniazid. Also, some of anticonvulsants may cause lupus. And you can see most of these drugs can be used also in a pregnancy, and this makes sense because drugs used in pregnancy usually tend to have large volume of distribution so that they can cross the placenta. And when a drug has large volume of distribution, it has larger access to tissues, and thus it can trigger antibodies. The pathogenesis is similar to SLE. There is activation of the immune system, but the antibodies are different, and this is important. In drug-induced lupus, the anti-double-stranded DNA is normal or only moderately elevated. Complement is not decreased, but we have elevated level of single-stranded DNA titer and anti-histone antibodies. Also, as I said, there is no renal and CNS involvement. It is a mild form of disease. Okay, and the condition will be corrected after discontinuation of the drug. Okay. Also, SLE, I'd like to mention, is associated with a syndrome known as antiphospholipid syndrome, which could be primary in 70% of cases or secondary to SLE in 20 to 30% of cases. I will discuss it in a later video. Now let's talk about the management of SLE. First of all, most important is education of the patient. We have to tell the patient to avoid sun exposure, to decrease, to stop smoking. This is very important, and also exercise is very important. Now, what about the drugs used in SLE? We will treat according to the condition. If it is mild, including only the skin or the musculoskeletal system, or severe if there is involvement of the kidneys or the central nervous system. So in mild disease, the condition can be corrected with NSAIDs alone. This is the first line of management. Non-steroidal anti-inflammatory drugs for mild disease. If the patient is not responding to NSAIDs, we can give hydroxychloroquine, which is an anti-malarial, but we don't know what its job in rheumatological diseases. It's also used in rheumatoid arthritis. If the patient is entering into more severe form of the disease, and that she may have seizures, proteinuria, then we start with more aggressive treatment. We may start with corticosteroids, prednisone, maybe the first line, and if the patient is not responding, we will proceed to biochemical agents like cyclophosphamide, azathioprine. We often give these biochemical agents along with prednisone, so it's a combination. Also for renal, there is a combination of mycophenolate with prednisone. Mycophenolate and prednisone is used in renal in lupus nephritis. And cyclophosphamide has very important side effects. It causes hemorrhagic cystitis, and we can give this. We can decrease this by giving a drug called mesna along with it. It decreases the incidence of hemorrhagic cystitis. So this is the main treatment. First of all, education of the patient, then drugs. If the patient has mild disease, we can start with NSAIDs. If she is not responding, we can use hydroxychloroquine. If the patient is having more severe form of disease, the first line will be a corticosteroid like prednisone, and if she is not responding, we will start with cyclophosphamide or azathioprine along with prednisone. Okay, and there are some conditions that present as SLE emergencies, such as severe CNS disease, systemic vasculitis like mesenteric vasculitis, alveolar hemorrhage is an SLE emergency that may need plasma exchange, condition known as thrombocytopenic thrombotic thrombocytopenic purpura-like syndrome, in which there is severe thrombocytopenia. This may need intravenous immunoglobulins, and also rapidly progressive nephritis is an SLE emergency. And that is all what you need to know about SLE. Thank you.